Thanks again for joining. Today is April 5th, and we are doing the version 6.23 upgrade, starting with the valve procedure section. On the phone with me today from STS, I have Leanne Jones, Addie Dolan, Emily Conrad, Melinda Offer, and Chastity Wellnitz. Thank you to Dr. Jacobs for joining us today. And also for my QVIA, we have Michelle Choi and Joe Brower on the line. So we're going to get started here. Please be sure to submit your questions using the Q&A. Today I saw the first cardinal in the south side of Chicago, I think. So it was good to see, and it means that the flowers will be popping up here soon, which is really great. We're going to start with the mitral valve section on the version 6.23 data collection form. Currently, the form still says version 6.22. It's just, we will update it to say 6.23 in the coming weeks. And then we'll take time for questions. So STS updates, the task force approved the new go live date for January 1st of 2023. Thus the change of the version name. No other major changes have occurred to the version, just the date of go live, which corresponds to the year. Harvest reports for fall 2021 will be released at the end of April, and then the spring 2022, as a result of the delayed release of the fall 2021 reports, the harvest for spring 2022 has been extended to Monday, May 16th, with opt-out on Wednesday, May 18th. Here's a quick overview of our planned upgrade webinars. Even though we will be going to a go live date of January 1st, 2023, we're still going to keep on going with these educational webinars. They will be recorded, so you can go back and listen to them. They're posted on the STS database YouTube channel, which you can access through the national database page. Today's April 5th, we'll be doing valve procedures, and if we get time, we'll be doing other cardiac, other non-cardiac, and then the VAD section. The first three are focused on the adults with congenital population, so we'll be talking about that, and then the VAD section is for all patients. April 12th, hopefully we'll get started on the aorta, which will extend into the 26th, where we'll go into the post-op events, hopefully as well. So I'm going to go over to that now, and then we'll take questions at the end. Usually, I'll watch the questions coming in, and at about the half-hour mark, I'll check to see where we're at with questions, and if needed, we will stop the review and go over to questions and things like that. So first, the first part where we're going to pick up at is this M4, which is the mitral or systemic AV valve procedure. I'm going to make this a little, there's nothing really on the previous data collection form from 341 that corresponds to this. So I'm just going to make this a little bit bigger so we can take up more of the screen and you don't have to squint. Okay. So again, we're in the valve section, and I'm going to do a quick review. I don't know if everybody was on the call, I think last week when we started in the aortic valve section. I'm going to do a quick review of the parent-child relationships that occur up in the operative section. Remember, we talked, for those of you who are on, we talked about how the parent-child relationships, the parent relationships will open up the fields for the valve section for patients who are 18 and over. And when we get up here, we're going to talk about this section here. So we have, and I apologize for the scrolling, we have operation type. So if it's a CPB or no CPB cardiovascular, and the patient's 18 or over, the purple fields will open, the fields with the purple background will open. And this is where we're getting into the valve procedure now. So as I said, we'll be talking about the mitral valve procedure. So you have to have a CPB cardiovascular or no CPB cardiovascular, and the patient needs to be 18 or older. You'll get these fields open for mitral valve. You'll have the four options of yes, planned, yes, unplanned due to surgical complication, or yes, unplanned due to unsuspected disease or anatomy. We have to update, this will need to say M4, so we'll need to update some of these gray text here. This is just to help you as you're abstracting if you're using the paper form to help guide where you need to go. So yes, planned is the patient entered the OR. It was consented for before the patient entered the OR. And this is what they plan to do, and the patient's aware of it. The yes, unplanned due to surgical complication. This was not on the consent when the patient entered the OR. It's something happened during the originally planned procedure that is now causing a mitral procedure, a common AV or systemic AV valve procedure to be performed. And then unplanned due to unsuspected disease or anatomy. And the surgeon opened the chest. They started doing a consented procedure. They realized that the mitral valve was extremely, had a lot of regurgitation or something like that. And they decide that since they're already in the chest and they're doing another procedure, that it's worthy to do a mitral valve procedure or common AV or systemic AV valve procedure on that patient. So unsuspected disease or anatomy. So if you answer yes to any of these, if you pick yes here for this option, any of these yeses, then the section M4 is going to open, and the same thing, I won't keep on scrolling back, but the same thing happens when we get down to the tricuspid or the pulmonary and neopulmonary valves. The same options are applied, and these will open the corresponding sections below. So your patient's 18 or over, and because we manage the age of the patient up above in the parent, we don't need to look at the age down below when we get into the children field of those operation types. The parent is already accounted for, so we don't need to look at the age again. And my screen froze, sorry about that. So we don't need to look at the age again. So you will not see the age explicitly stated for these purple fields because it's managed up above in the parent field. Okay, so we're back down in the valve section. We went through the explants previously, and we did the aortic valve on the last call. So up above, they coded that a procedure was performed on the mitral valve, common AV valve, or systemic valve, a systemic AV valve. So you're going to get these questions, and notice we don't ask if the patient is 18 or older here. It's already handled up in the parent. So your first question is going to be which valve, and you're going to select which valve the procedure is performed in, mitral, common AV, or systemic AV valve other, and then which procedure was performed. We have here repair, replacement, or surgical prosthetic valve intervention, not explantive valve. These are your harvest codes or your options for which procedure was performed. If you performed a repair, you're going to be asked the repair approach, which is either surgical or transcatheter. If it is a surgical, then you'll be asked what type of surgical repair was performed, and you can see the list here. We'll provide detailed instructions in the training manual, which is expected to be out hopefully before AQO, that goes through the different repair types, surgical repair types. If your repair type is a leaflet resection, the next set of questions regarding that, it's resection location. So if it was anterior, posterior, or both, and then the method that was used. For neocords, you'll be asked if you coded neocord as the surgical repair type, you're asked what anatomical location of those neocords. Anterior, posterior, or both, and we'll provide as I said, and I keep on referring back to the training manual, which isn't available, but just to kind of walk through and show how the parent-child relationships work and what we're asking is really the purpose of these calls. We'll get more into the definitional clarifications in the training manual, but if you have questions on this, we can certainly try to answer those now. Neocords, anterior, posterior, both, the chordal transfer, anterior chordal transfer, posterior, both, or I'm sorry, not documented, and then leaflet extension replacement patch, where that patch was located. Now, if your procedure type is going to be replaced, if your procedure for the mitral valve is a replacement, you're asked if the valve repair was attempted prior to replacement. So for purposes of these adult specific fields, sometimes my mouse does wonky things and I apologize for that. If we're looking at replacement work, the first question is if a repair was attempted prior to replacement. For these adult specific fields, we're only capturing if the patient comes into the OR and the plan was to repair, but then they ended up doing a replacement. We're only capturing the last procedure that was performed on this data collection form. So you're going to code the replacement for this case, and then you're also in the replacement, you'll be documenting that a valve repair was attempted prior to the replacement. You will not actually be documenting the attempted repair, just that it was attempted. And you do that here underneath the replacement. And then it asks about preservation of the valve cords and if it was a transcatheter replacement. And a failed repair converted to replacement. Oh, I apologize. This is if the first one, valve repair attempted, I got these two fields screwed up. I apologize. The valve repair attempted prior to replacement is in another operative setting. The failed repair is in the same setting. So we'll clarify that in the training manual. Valve repair attempted prior to replacement, different operative setting. Failed repair converted to replacement, same operative setting. And that will be clarified. And then we get into the surgical prosthetic valve intervention, which is not an explant of the valve. The explant is captured in the sections above where we discuss explants. But if they perform some type of intervention, like a repair of a periprosthetic leak, a removal of a pannus, or removal of a clot, that's on a prosthetic valve, that would be captured here. And then the types of implants. We do have options for the transcatheter. If a transcatheter device is implanted open heart, which can be done, they will use a transcatheter device, but they do not insert it via catheter. They insert it open in the open position, which means the chest is opened to put the heart is open to put that device in. That's what this is referring to. These other two transcatheter devices are specific to that they were inserted via catheter and either transapical or transseptal. Transcatheter devices, and Chastity, you might have to correct me here. For transcatheter devices, we don't require these always to be captured. Do you require them to be captured in the congenital database?
As standalone procedures, are you asking, Carol?
Yes. Mm-hmm.
Only if it would have surgeon involvement in placing.
Okay. So I'll assume that we do the same for this, and we'll provide that direction. I think it's a little bit different than historically how it's been done, but we'll provide the direction for transcatheter specific devices with surgeon involvement to be entered into the database. If you do a mitral leaflet clip, how many clips were inserted, and then implant model number, implant size, and a unique device identifier if you have it and it's not manually typed in. We get into the tricuspid non-systemic AV valve procedures. We if there was a procedure performed, is a repair, replacement, surgical, prosthetic. Things kind of get slimmed down here when we get past the mitral valve. When we look at tricuspid and pulmonic valves, it's not as granular. So just thank the Lord for that. That different questions here related to if an annuloplasty was performed, if a repair and it was an annuloplasty type repair, what type of annuloplasty, and if it was a replacement transcatheter or failed converted to replacement. Failed repair converted to replacement, same procedure. And then if a surgical prosthetic valve intervention, not an explant, was performed, and the same reasons as listed above for the other two valves. Implant type, we're looking mechanical annuloplasty, prosthetic, homograph, transcatheter, implanted open heart, transcatheter, valve, or other, and then the same information. We're also looking here, different question that is not above up in the mitral section or the aortic valve section is if a valvectomy was performed. So that's a kind of a special question for the tricuspid section. So if a valvectomy was performed, you'd capture it. And then pulmonary or neopulmonary valve types of procedure, repair, Pannis thrombus removal or replacement. If it was a replacement, transcatheter, and was it a failed converted to replacement? This question is, we kind of combine those two up above, and I'm not sure why we did it differently here versus how we did it up in mitral. But yes, this procedure, yes, this episode of care, or yes, both during this procedure and during this episode of care. Seems like we got redundant up in the mitral section, so we'll need to make sure we provide very clear information on how to code those fields up there, when it seems like we could have just added one field with all these options. Valvectomy, and then the implant type, surgeon fashioned, commercially supplied. If surgeon fashioned, PTFE Gore-Tex, pericardium or other. If commercially supplied, then the device type. And then, okay, I'm going to move on down to the other cardiac. Melinda, is there anything specific that you wanted to add that maybe I skimmed over too quickly for the valve procedures?
I don't think so at this point. I think you did a really good job on laying out the fields.
Okay. All right, other non-cardiac procedures. So again, up above in the operative section, there is a question that has a parent on it that asks if other cardiac procedures were performed. The same thing with other non-cardiac procedures. For other cardiac procedures, there's just 4 that are of concern. We're looking for subaortic stenosis resection, if it was cardiac trauma, acquired VSD repair, and ASD repair type, if an ASD was repaired. For subaortic stenosis, this will become a select all that apply, muscle, membrane, other, or not documented, trauma cardiac, I think it's self-explanatory, but we'll provide definitions of what a trauma is, and if a trauma occurs outside of the OR versus inside of the OR, how to handle those specifics of the case in question. Acquired VSD repair, if it was surgical or device, and then ASD repair type, congenital, which includes secundum, coronary sinus, and sinus venosus. And if it was acquired, congenital versus acquired, or none. And then the only thing we're capturing under other cardiac procedure is if a carotid endarterectomy was performed, and if it was planned, unplanned due to surgical complication, or unplanned due to unsuspected disease or anatomy. If your patient enters the OR and on their consent, it's for a CABG and a carotid endarterectomy on the consent form, that's planned. So it's not due to unsuspected disease or anatomy, since the surgeon's entering the OR with it already in their mind of what they're going to perform, and that includes a carotid endarterectomy. If they get into the OR and say it's an emergent or a salvage type case, and the patient has stenotic carotids or tight carotids, with significant stenosis, and they decide at the same time that it's really beneficial to that patient to undergo carotid endarterectomy at the same time as that procedure, but it was not on the consent form, that would be unplanned due to unsuspected disease or anatomy. And then we get into the AFib procedures. Thankfully for this, we're only asking 2 questions. One is a left atrial appendage amputation performed. So did they remove the left atrial appendage, completely remove it? And we'll provide information on that. Sometimes they put clips on the left atrial appendage, which does not count as an amputation. An amputation is complete removal of the left atrial appendage, and we'll provide the difference between those 2 types of procedures and when this would be coded no versus yes versus no. Lesion location, if they do a maze procedure, isolation, they could do it epicardial, intracardiac, they could do both or none. Epicardial means that they don't enter the heart, they don't make an incision into the myocardium, that they're just performing on the outside of the heart muscle. Intracardiac means that they enter the heart. And there's different methods that they can use for lesion location. These are used, I don't know how familiar in the congenital database, how often AFib procedures are performed, since it's probably more of a elderly population where these types of procedures are performed for AFib. But there's different ways that they can do these, and we'll provide instructions, or I guess clarification, on what epicardial is versus intracardiac. Sometimes the wording there can be overlap in wording. So we'll provide clear instruction on those, and the terminology that we've heard, and how to use that terminology to determine if it's epicardial or intracardiac. And this, the AFib procedures alone will probably be a good webinar. We've talked about a few other things, like looking at the aortic valve procedures and looking at the CABG procedures as separate webinars, where we really focus on what's in the training manual. So once we have that training manual out, we'll be providing, I think this is going to be AFib will be a good one. We'll be providing focused webinars for these types of procedures to help with coding and answering questions once you start abstracting this version. Radio frequency cut and zone cryo are all types of ablations, lesion locations that can be performed. And they can be performed either epicardial or intracardiac. So we'll clarify that as well. The next section is the VAD procedure, and Chastity, I can hand this over to you. Melinda, did you have anything to provide further on cardiac or non-cardiac or AFib procedures?
No, not at this point. Without the training manual being done, it's kind of hard.
Yeah. Okay, thank you.
Oh, so this is Dr. Meyer. Could I just ask, do we have, is it possible to do these sort of cryoablation things, or how to code the cryoablation things for something other than atrial fibrillation? I mean, do we require an atrial fibrillation diagnosis, or is it the ANT arrhythmic procedure itself?
Yeah, that's a good question, and we do have clarification on that. Melinda, do you want to speak to that?
If we currently in the adult training manual, how we handle that is, if the patient, the surgeon gets in there and he decides he wants to amputate the left atrial appendage, there's no history of AFib, but he just wants to amputate it as preventive, then we have them code AFib procedure, and then code yes to the amputation. So I'm thinking along the same lines, if the surgeon gets in there and decides he wants to do like a PVI or something, a pulmonary vein isolation,
Right.
then I assume we'd code the AFib procedure yes, and then we would code what was actually done.
Okay, so, I wonder if we shouldn't be thinking about maybe recoding this or restating, titling the category, because it's atrial arrhythmia procedures. I can tell you that in the congenital world, particularly in the adults with congenital heart disease for whom this is to be utilized, we have situations where somebody's got a big dilated atrium because of longstanding tricuspid valve disease or mitral valve disease or something, and we're sort of doing quote unquote prophylactic maze-like procedures. And I think that's done enough, at least in this institution, that I think we need to have a way, make sure we have a way to enter those kinds of things, those kinds of procedures.
Yeah, understood, Dr. Meyer. I believe like Melinda said, in the adult database, the AFib procedure equal to yes is for prophylactic procedures. So, and I hear it, what you're saying, wouldn't necessarily, we don't know, the patient doesn't have a diagnosis of AFib, so it technically is dysrhythmia or an arrhythmia preventive procedure, which doesn't necessarily mean it's AFib.
Right.
But we can definitely clarify, and if wording needs to be updated, we can work on that too. Mhm.
Okay, thanks.
Yep. Thank you. Okay.
Okay, so VAD
Oh,
procedure.
Chastity.
Oh, boy, welcome to
Let
the
me,
party.
yeah, welcome to the party.
Okay, so there's not a whole lot of change here other than more along the lines of removing some fields or moving them around. So what you see first, and the new data collection form 6.22, soon to be 6.33, you see that we added the word device in front of destination, and then also included under indication salvage and device infection. And then as well as changed a little bit about how we were recording the first implant type. So I don't think for functionality within your software, you'll notice a lot of change here, but essentially we moved this around a little bit. And then was there a VAD related complication? You of course would answer yes or no as the parent field. And then if yes, you're answering some other related questions. One new question that we added was the explanted device implanted at another facility? And so this is where a patient arrives to your facility with a VAD already in place. That way, upon analysis, one can look at the complications associated with a VAD that you implanted versus another facility implanted. And so then indicating the complications are the same. It's just that this is becoming a multi-select field as opposed to yes, no, yes, no, yes, no, next to all of these. So as we scroll down, you can see again, more multi-select fields. And so not a lot of changes to this section, more changing the type of the data field and adding a few more indications. And that's all I have about the VADs. And this will be for all age groups.
All age groups. Very
All
good,
age groups.
Chastity. Good job.
Thank you.
Okay. Our next section is the aorta section. So before we go there, we have 3 questions, and the 4 questions in the chat box here. The aorta section is a big section, so let's do these 4 questions and then we can work on the aorta section if we get there. We have about 30 minutes left, so we should be okay. The first question, valve procedures for the greater than 18-year-old don't need to be completed for operation type VAD with CPB. Right, it's just the, sorry for scrolling again. I wish I had bookmarks I could just click somewhere, but it doesn't work that way on these forms. So it's operation types CPB cardiovascular or no CPB cardiovascular and greater than 18. We don't look at VAD with CPB.
I think the reason she's asking that is quite often during a VAD, they close the aortic valve, but we don't, currently in adult, we don't even code that as a repair. Just
It's all part of the VAD
part of the
procedure,
VAD
right?
procedure. So that may be where that question's coming from. I'm wondering.
Thank you, Melinda. If conversion happens during this procedure, isn't it obviously during the same episode of care? This seems redundant. Clearly, you're right, Crystal. And I'm not sure. But I think we're going to have to provide a little bit more clarification upon what this episode of care means or this procedure. And both during this procedure and during this episode of care. I think that there's a difference between if a patient, had an attempted procedure at another facility and then came to you, it would be a little bit different than if they were at your hospital, I guess, is what the surgeons were going with here. But we'll work with Dr. Nelson and Dr. Scholl to make sure we have this very clear in the training manual. For clarification for the ASD and BSD repair methods, for the selection of devices, is this including devices done in the cath lab not completed by CT surgeon?
We
And
don't
Chastity,
include-
I'm probably gonna let you take that one because
Yeah.
I would, my guidance would just be the procedures performed by the surgeon, but
Yeah,
I'll let you
if,
take that
can
one.
this is
Oh,
Jeff.
sure. Yep, sure.
I think if it's a device placed purely by an interventional cardiologist, then it would not go into the congenital heart surgery database. However, if the surgeon either places the device or provides a surgical procedure for exposure to place the device, and therefore the surgeon is scrubbed and actively participating in the case, then it would go into the STS congenital heart surgery database.
Ditto.
How'd I do, Chastity?
You did a great job, Dr. Jacobs. It was all that rush we played.
There you go. It's got me fired up.
Thanks, Dr. Jacobs. Okay. Can the VAD wording be made more to clearly specify how to code a systemic VAD and say a hypoplast where it is not technically the left ventricle?
Yeah, this is a great question. A lot of times nowadays in the congenital world, when we think about ventricular assist devices, we can have an LVAD or an RVAD for a biventricular heart, but in a functionally univentricular heart with one ventricle, it's going into the single ventricle, which is usually the systemic ventricle, but can be a morphologic left or morphologic right ventricle. And I would think in the future, we can modify the data collection form to more precisely handle those issues. But within this upgrade where we're using what we have now, I think the best thing to do is to code it as an LVAD since it's working as a systemic ventricular assist device, but the diagnosis would be either hypoplastic left heart syndrome or some other functionally univentricular heart with a dominant right ventricle. And that would provide the information to STS that it's a systemic ventricular assist device and a morphologic right ventricle functioning as a systemic ventricle. I think that's the best we can do with the current data collection form. And we may improve this in the future, but for now, you just code the diagnosis and code it as an LVAD.
Great.
How'd I do on that one, Chastity?
I like it. It works for me.
Write it in your notes, Chastity.
I got it. Got it.
Thanks, Dr. Jacobs. From Angela, Intermax changed their complication categories. Was the intention to match Intermax complications and STS VAD complications? They currently do not match. I would have to review what the differences are, Angela. We did work with, I think that we just pulled over what was previously collected so that we would be able to map the versions. But happy to review that.
Yeah, we've made efforts to harmonize as much as possible between Intermax and PDMax and between Intermax and the adult cardiac database and PDMax and the congenital heart surgery database. So efforts are ongoing to harmonize those things. That's what we've tried to do on all sides, but there may be a lag when one gets changed before the other gets changed.
Thank you. And but biventricular VAD, if biventricular VADs are placed in a total artificial heart configuration, how would we code that?
Well, if it's a BiVAD, you code an RVAD and an LVAD, but if it's a total artificial heart, you code total artificial heart.
Yeah, it's two different devices.
Yep,
Thank you.
exactly. John's absolutely correct.
Okay, and then Angela's saying that the Intermax complications were changed in October of 2021. And that was long after this section was already completed and being programmed for congenital. But as Dr. Jacobs said, we do try to harmonize as much as possible. So it's something we can continue to look at. Thanks, Angela, for letting us know. Okay. What do we say about going into aorta, Melinda? Did you have enough coffee yet?
I think we could start aorta. I think we need to go back up to the part where the selection of the procedure and kind of go over that first so everybody understands that, and then talk a little bit about, I think if we just get through the history and how to get into the section, that's probably be good.
Okay. Do you want to take lead on this one?
Yes, I'll talk about, I love aorta procedures.
We all do, yeah.
We all love
Okay.
aorta procedures. So, if you have an aorta procedure performed, and this is the first thing I want to say, this is a true aorta procedure. So sometimes you'll see in op notes where they're doing an annular enlargement when they're doing an aortic valve. And currently, the direction we have in our training manual is that's not really considered an aorta procedure. So we're talking about replacing an ascending aorta or doing a Bentall or a root or something like that. So is the aorta procedure planned? It was on the consent. Was it unplanned due to a surgical complication? So I call those the oops procedures. They get in there, they nick the aorta, they have to go in and fix it. That's a complication. Or was it unplanned due to unsuspected disease or anatomy? So they get in there and they're then initially they're going to do the like an aortic valve procedure, but then they get in there and they realize, oh, this aorta is pretty dilated. We're going to have to fix that too while we're in here. So it's new anatomy, unsuspected disease. So they plan to go ahead and do the aorta procedure. So if it's just an aorta procedures, which is what we're talking about now, you would just code sequence 1765. If it's an aorta valve procedure combined with an aortic valve procedure, then you have to code aorta procedure, then you have to code valve procedure, and then kind of go through all the valve sections. And it's a little redundant when you get down here, but it has to be. All these things have to be coded. So we're doing a Bentall. So yes, we plan to do an aorta procedure. Yes, we plan to do a valve procedure. Yes, the aortic valve was planned. And then sequence 1785, yes, we did perform an aorta procedure. So all of those have to be coded in order to properly open all of your child fields up into the aorta section. Okay. If we can move on to actually getting into the meat of this a little bit. And I'm going to say first off, this section is overwhelming for the adult people too. So, and we've been doing this for about 4 or 5 years now, and still it is a difficult section for everybody. So I'm just throwing that out because I know this is going to seem overwhelming. So the first thing we're going to do is get some history about the patient. Does the patient have a family history of disease of the aorta? Whether that be a history of aneurysm, dissection, sudden death, both aneurysm and dissection, or you don't know that they have a family history. And then the second question is, does the patient have a genetic history of aorta disease? So do they have Marfan's or Turner syndrome or some sort of aortic valve morphology? So we're looking at genetic history. And then the third history question we want to know is, has this patient had a prior aortic intervention? And if so, we want to know where that intervention was. Was it in the root, the ascending, the arch, the descending, or the suprarenal or infrarenal? And then the repair type, was it open, was it endovascular, or was it a hybrid where they did both repair types? And then was there a repair failure of this previous intervention? And if there was a repair failure or was there disease progression? So we're getting a good history about the patient's aortic history and prior interventions. the next question is, does this current procedure that you're doing right now involve an endo leak? So, and if so, it talks about the types of endo leak. Now, in the training manual currently, in the adult training manual, we have some really nice pictures of each type and descriptions of each type of endo leak to assist the data manager with correctly coding the type of endo leak.
You want to explain what an endo leak is, like briefly?
Oh wow, let's see. So it's where you repair the aorta and then it leaks around the repair. That's really not a very technical description. If Dr. Jacobs or Dr. Meyer have a very technical description, that would be great. But that's how I imagine it in my mind, and it makes it easier for me to understand.
This is typically for after a prior endovascular stenting or that type of procedure, right?
Yes, that's right. It's from a previous procedure.
Right. So in order for that to work, the device, particularly a covered stent, has to seal up against the wall of the vessel to exclude, if you will, that part that's become aneurysmal. And where the problem can arise is that if that seal is incomplete, then the blood can still get out around your endovascular graft and into the aneurysm that you were originally trying to treat. It's going to be at lower pressure, but there's still an incomplete seal of this endovascular device to the inside of the blood vessel that you're trying to cure the aneurysm, for which you're trying to cure the aneurysm by putting a graft inside it.
Thank you very much
Good.
for clarifying that. So the next question, current procedure. So the current procedure that you're doing, is there an aorta infection involved? And if so, what type of infection? Is it a graft infection or a valvular endocarditis or a non-valvular endocarditis, a native aorta infection, or are there multiple infection types? The next question is, the current procedure that you're doing, does that include trauma? And if so, where is the location of that trauma? Is it in the root, the ascending, the arch, descending, thoracoabdominal section? And then we move on. We want to know the presenting symptom, and you can only choose one. So you choose the most prominent symptom that the patient is presenting with this aorta issue that you're going to repair. And if you choose neurodeficit as your presenting symptom, then we're going to further break that down and choose whether the patient's had a stroke or he has limb numbness or paralysis or acute vocal cord dysfunction. So now, once we get through kind of all the risk and history of the patient that we've broken down, then we're going to move into the primary indications for the aorta procedure. We have three choices at the beginning. We have an aneurysm, a dissection, and then an other category. So we'll go through the aneurysm category. So if you choose it, excuse me, if you choose aneurysm, the aneurysm section is going to open up, and the first question that you'll be asked is what is the etiology of this aneurysm? And there's a lot of choices here. You can only choose one. Choose the primary etiology that's driving the surgery. Then we want to know the type of the aneurysm, whether it's fusiform, saccular, or unknown. Then we want to know, did the aneurysm rupture? And if it did rupture, is this a contained rupture? And in the training manual, this is pretty laid out pretty carefully and clearly so that you understand what we're asking here. Then we need to know the location of the maximum diameter of the aneurysm. And we're really looking for, surgeon direction here and documentation. Like I said, the training manual is pretty laid out. But when we first started doing the aorta procedures in adult, a lot of this stuff was not documented very well. I'll just put it out there. It wasn't documented very well. And we told the data managers, don't guess, don't make this stuff up. If it's not in the chart, it's not documented, then leave it blank, because we'd rather have good data than inaccurate data. So as we've done these adult procedures in the aorta, these aorta procedures in the adult database, we've evolved in where programs, I think, are documenting much better now. We have worksheets that assist the surgeon in documenting this stuff. And so the data managers, I think, now are getting more information documented. But in the beginning, you'll notice that you may have trouble getting some things done, and don't hesitate to leave things blank if you don't know what the answer is. That's what I'm getting at, because we'd rather have good data. So the timing of the, that's aneurysm. Okay, so that's the aneurysm questions. So if your etiology is aneurysm, if your etiology is dissection, your primary indication, we're going in to fix a dissection, the first thing that we want to know is the timing of this dissection. So is this hyperacute, less than 24 hours? Is this acute, 24 hours to 2 weeks, subacute, chronic, acute on chronic, or unknown? And then what is the onset day of the dissection? And then what is the primary tear location of a dissection? And in our training manual currently, we have some really nice pictures that show you exactly where these zones are. And I think as we get more into this aorta, probably we don't have much time on this call, but we probably need to bring those pictures up and show people.
I would bring them. I can bring them up quickly here, I think, if they're going to be where we're at. I'm surprised nobody asked.
There was one.
Yeah.
So you can see that we've, like A, B, and C, you can see where they are. So A is below the sabrotibial junction. B is the sabrotibial junction to mid-ascending. C is mid-ascending to distal. And then each zone is clearly defined where it's at. So zone 1, between the innominate and the left carotid. Zone 2, between the left carotid and left subclavian. Zone 3, first 2 centimeters distal to the left subclavian. So, and it kind of just goes all the way down through zone 11. And so the pictures are throughout the aorta section. So they're not just in one place. So as you're scrolling through your training manual, you'll see these pictures repeated over and over to assist you in coding these types of procedures. I think we may have to, we only have about 7 minutes left, Carol. You can go a little bit further if you think, or should we stop and then just pick up dissection again?
Well, let's see if we can get through the dissection part. We just have one question and we can answer that pretty quickly.
So then they want to know, after you identify your primary tear location, they want to know proximal dissection extent known. So do you know how far approximately this dissection went? And if you do, where is the most proximal dissection location? And then the same thing they ask about distal dissection extent known. Do you know how far down? And if so, where is it? And then the type of dissection. So is this a type A, a type B, unknown, or an other? And again, those are clearly laid out in the training manual. What is a type A? What's a type B? What's an other? Then retrograde dissection caused by aortic stent graft post TVAR. That's just a question. It's not like an accusatory question. We got a lot of questions about that when we first added this into our adult form. That basically we just want to know, is this patient post TVAR and did they have a retrograde dissection caused by that? And
What's
then
a T-bar, Melinda?
oh, a TVAR. Wow, gosh darn. Okay, I'm sorry. So a TVAR is it's a transcatheter endovascular aortic repair. So it's sort of like a TVAR of a TAVR in a way, because you're doing transcatheter and usually going up the groin and you're inflating stents. But in this particular transcatheter procedure, the stents are going into the aorta. Okay? And we'll talk more about TVAR as we get down because we have a whole section on endovascular aorta procedures.
Thank you.
And then was the patient 30 days post TAVR? Okay, so yes, no. Again, it's just an informational question. Was the patient 30 days post any other kind of cath procedure? Informational question. Then if the patient has dissection, is there malperfusion present? Yes, no, or unknown. And if there is malperfusion, the surgeon documents malperfusion. What's the location? And this is a select all, so you can choose more than one area that might be malperfused by this dissection. And then we want to know, does the patient have lower extremity motor function? So are they having issues with it? It's no deficit, weakness, paralysis, or we don't know what their lower extremity motion is. And then we want to know about any sensory deficit that they might have in their lower extremities. So yes, no, or unknown. Again, was it ruptured? Did the dissection rupture? Was it contained? Yes or no? And if it did rupture, where is it at? Where did the rupture occur? And then I think we can do other really quick. The third choice for primary indication is other. So we've already addressed the aneurysm. We've addressed the dissection. Here's our other category. So valvular dysfunction is a choice. Stenosis, obstruction, intramural hematoma, coarc, an endoleak, infection, injury related to surgical complication or perforation, or trauma. And you can see these are different. Okay, so trauma is blunt trauma. And then we have a choice for injury to surgical, due to surgical perforation. Okay.
Great job, Melinda.
Yep.
Just the one question is from Becky Sam is, will the worksheets mentioned be available on the website for us to give our surgeons when we perform an adult case? We will make them available, and we'll probably currently on the under the adult, we're in version 4.20 in adult. We have the worksheets available now, and we'll probably just pull over with some minor tweaks all of the aorta ones that we have available. So you're free to check those out now if you wanted to. But yes, we will make these all available for the aorta, probably for all of the sections that we currently have available over here in the adult side. Okay. Thanks, Melinda. That was a really nice start to the aorta section.
You're welcome.
It looks like we're at time. Do we have any more questions? Okay. All right. Thank you, Dr. Jacobson. Thank you, Dr. Meyer, for joining.
Pleasure.
Thanks, everybody,
Okay.
for joining. Hey, I hope you have a great rest of the day. And our next call is, do we have a call next week?
12th.
The 12th, next Tuesday. So see you all next Tuesday, and we'll pick up at the aorta section under additional anatomical information. Thanks, everybody. Have a great rest of the day.
Chastity.
Yeah,
Great
thanks.
job.
Thanks, Chastity.
Good
You're
job.
welcome. Thank you.
Bye.
Bye.